recording. Thank you. Take it away, Hudson.
Thanks, Trudy. Yes, well, just about a year ago, the Therapeutic Goods Administration, TGA, announced that henceforth psilocybin would be able to be prescribed for chronic depression untreatable by any other means, and MDMA, street name ecstasy, would be available to treat people who have post-traumatic stress disorder untreatable by any other means. It was a big surprise to pretty much everybody. One of the surprises to the people I work with is that they only made two stipulations when they made this approval. One was that the therapist had to be a psychiatrist, and the other was that a human research ethics committee had to approve every therapist. They didn't consult with us beforehand, and they also didn't tell us what guidelines they would like us to use in making such approvals. So they call this the Special Access Scheme, also the Authorized Prescriber Scheme, and it says that human research ethics committees, henceforth ethics committees, have to evaluate and monitor such programs and consider new information as it comes along. They said we had to determine for ourselves what evidence is appropriate. Now, there are a couple of hundred of ethics committees throughout Australia, and I'm pretty much in touch with most of my colleagues. We have an annual conference, so we talk to each other. And the vast majority of ethics committee chairs said, we're not going anywhere near that. My committee said, yeah, we'll take that on, for a couple of reasons. One, ethics committees are certified at different levels, stratified. Our committee happens to be certified at the highest level that the NHMRC, the National Health and Medical Research Council, authorizes or certifies ethics committees, so we can take on all kinds of applications for research. Research in First Nations people, research in children, mental health research that isn't really health related at all. And so we're probably a little bit more accustomed to risk, to taking on risk ourselves. Also in Townsville, there's a big military population with a big burden of PTSD. So we know that as this goes on, it will be of great benefit to people in our area. I say as this goes on because as we speak, anybody who's eligible for this therapy has to have two attributes. One, they have to be seriously ill with depression or PTSD. And two, they have to be seriously rich, because these therapies are going to cost $30,000 per session because of the amount of time spent with a psychiatrist and the logistics that go along with it. As I say, TGA didn't give us any idea what we were supposed to look at, how we were supposed to approve this, what dosage, what is the mode of therapy, and the video they steered us to showed the patient in a hospital bed, blindfolded, with headphones on, listening to new age music in a brightly lit room with a psychiatrist on one side and some other suitably trained, person on the other side. Well, we said, well, what if the person wants to listen to Mozart or the Grateful Dead or, God forbid, Metallica? And why does the room have to be brightly lit? How are we going to establish criteria to approve this? Well, we set about doing so. And to get to the end of the story, we ended up doing so. We have a guidance document that we're now sharing. There's only one other ethics committee that has taken these on. There are three providers approved so far, one in WA, one in Victoria, and one in New South Wales, the one we approved. One of the fortunate things that happened was I had some travel scheduled to Switzerland and Boston. My wife's son lives in Zurich, and one of my daughters lives in Boston. Zurich and Boston happen to be two major centers of psychedelic research. And as I said, the Swiss have been doing this as therapy since the 1980s. So I wangled myself meetings at both places and sat down with some people that knew a whole lot about this stuff and came back with a whole lot of information that we used to generate the documents that we have used to do our decision making. And a couple of decisions we made right away. We asked the hospital's chief psychiatrist, chief of pharmacy, and chief of medicines to form a core group to look at applications as we received them and pre-screen them and let us know if they thought they looked legitimate from their expertise realms. Another decision we made was that anybody we approved, we were going to approve not just as therapists, but as researchers. And we had two reasons for that. One, this is new, there's still a lot to be learned, and we wanted to, actually there are three reasons. We wanted people to capture what went right and what went wrong. The second reason is that our main goal here is to keep out the cowboys, the charlatans, the people that shouldn't be in this realm. There's already been one application that's been rejected by the other ethics chair who's been approving these. So those were the reasons. Oh, and the third reason is that if it's research, it indemnifies my community, my committee, and Townsville Hospital in case that anything does go wrong. So armed with that, we put together some guidance documents, and we received our first applicant actually last August. And we put that applicant off until November till we thought we were ready to approve them. The TGA says also that they have to approve everybody after the ethics committee approves them. So I called the TGA, and one problem I've had is every time I call the TGA, I have to talk to different people because the people change all the time. They get reassigned to different areas of the TGA. But I called them and said, instead of us approving, then you approving, and maybe you change something so they have to come back us for an amendment, and we have this loop, why don't we do it together? Well, they didn't really want to do that, but they did agree that we could talk. And I guess we did something right with our first approval because the TGA, whereas they'd said it was going to take them probably 6 months to go through the application, ended up approving it pretty early on. We thought this was worth doing because the evidence is really good. Psilocybin does really seem to work well for people who are severely depressed. The mechanics, as I say, still need to be worked out. And one of the things I learned from the Swiss is that they don't do this individual one-on-one or one-on-two, two therapists and one person being treated. I didn't use the word patient that time. But they do it in groups. And they do it at a high dose. These people seriously trip. And at the height of the trip, when they've peaked at a high plateau, they take them out for a nature walk. The Zurich Psychiatric Hospital is set in a very pastoral setting, lovely grounds, so they take people out on a walk. And what they told me is most of the insights, most of the breakthroughs come there. One of the other problems that we're still facing is that when somebody's enrolled in a research project, they have to sign a consent form. And you have to tell them what they can expect. Now, if that research is on a drug that's going to hopefully cure a disease, you tell them this is the drug, we hope it's going to provide this cure, we know that there are side effects, let's say headache or whatever, that you might experience. But how do you get someone to consent to something that's totally unknown? You're going to go on a trip, we don't know where you're going to go, we don't know what you're going to experience, we don't know what you'll feel like after you come down, and these are all important things that still need to be elicited. The other thing that makes us uncomfortable is there's still a lot of research going on where people are being enrolled into studies that are randomizing them into either psilocybin treatment, I'm going to focus on that for the rest of my talk, or placebo. Well, that kind of study doesn't work for psychedelic drugs. You can't randomize people against placebo because a placebo does nothing. People who are expecting a psychedelic trip are going to realize that they're not on one, realize they're not in the arm that they wanted to be in. And if, as I say, these are people who are seriously depressed, haven't responded to any treatment, and see this as their last best hope to get better, it's an amazing come down, amazing demoralization. So for that reason, I think it's really good that this is therapy and that this is allowed. But there's still a lot of work to be done. I'm going to pause there and see if anybody has anything they'd like me to talk about.
What was the dosage they were using in Switzerland?
The question is, what is the dosage that's been using? I don't remember the number in micrograms, but it was a very high dose. People I've talked to said, wow, that's, I think maybe 600?
Is there any facility for people to obtain it for less than $30,000 a pop?
Is there any facility for people to obtain it for less than $30,000 a pop? Right now, as we speak, no. Because you have to have it through this therapy. One of the things I like about this therapy is it's not like most therapies. You take this drug and it produces this cure. This is a synergistic treatment. It's the drug and the action of the psychiatrist that provides the cure, the two working together. And it's because psychiatrists are such highly paid individuals that that cost is high and is going to remain high until Medicare covers it or the folks that cover the military's health benefits cover it.
Oh, that was going to be my question. Is DVA actually meeting any of the costs?
Yeah, the question was, does DVA meet any of the costs? As we speak, no, they don't. And hopefully that will change. We also need to know more about treatment failures. There will be treatment failures. We've got to know a lot more about why those occur. And there are other people that are going to be speaking later, Dr. Williams for one, that have done this a lot in research settings, so we'll tell you a lot more about how it works in real life.
Just on the DEA side of things, are there discussions being held? I was led to believe it's talks are well advanced.
Are there discussions being held about covering it by the cover? I don't know that there are. I'm not in those loops, so I wouldn't know that that's happened. So again, looping back to where I started, we are the gatekeepers to all this research committee, research ethics committees, and there are only 2 of us now that are doing it. So everybody has to pass through us to get approved, and my committee is very comfortable with that. We had a really intense discussion before we approved the therapist.
Do you think there'll ever be an avenue for naturopaths to administer?
Do I think there'll ever be an avenue for naturopaths to do it? I think part of the future probably is going to be, maybe has to be, that somebody at a lesser level of training than a psychiatrist is able to provide the therapy. In fact, this is a specialty. And so I think we're going to see therapists from whatever realm who are adept at minding people through their trip, at bringing out certain aspects of the trip that are beneficial, and dealing with the negative aspects too. And of course, this is especially true in groups, whereas you can imagine if you've got one person that starts having something negative, that can follow through the group, a trigger.
Is there relapses with the ones that have been cured initially?
Are there relapses? There seems to be some evidence that for some people this doesn't work. They come out of the trip and they go, that was great, I talked to God, I saw sounds and heard colors, and now I'm back and I feel just as miserable as I used to. And so we need to find out why that is and what can be done about that.
So that was my question as well. How often would you have to treat, let's say, the patient? How often do you have to treat the patient? Only once, or it might be several times for the rest of their life?
The question asked is, how often do you have to treat a patient? The science says that one session works. There's plenty of evidence that for plenty of people that have gone through this in a research setting, they've come out of the experience and have been able to live normal lives.
They are then, highly resistant to traditional depression medication.
Well, that's one of the criteria for people to get into this. They have to already have demonstrated that they're resistant to those meds, that those meds don't work. So this is a last resort treatment right now, not a first line treatment.
No, that's kind of what I was getting at as well, because some people are highly resistant, and several treatments of psilocybin is more beneficial to them than just a single because of the resistance.
Several treatments may be necessary as opposed to single treatments. Anecdotally, I know of one person who suffered from chronic depression for years and years and years. And she did mushroom trips for years and years and years, and she still suffered from depression. But she tried ketamine therapy with a psychologist, and that worked. It cured her depression.
I was just wondering if there's any studies that you've gathered around the microdosing rather than having a full strength experience leading up to a full strength experience perhaps.
The question is, what about microdosing? Microdosing has a different mode of action. It produces different changes in a person and would be highly unlikely to treat the kind of things that we're talking about, the profound depression, profound PTSD.
Can I ask how long those particular studies and data has been collected for?
The microdosing studies, the research is just now catching up to where the street has been, to where people have been doing this for a while.
Very fresh and new, there's really no collective data.
This is all very fresh and new. There's not much collective data, and I have to admit I haven't researched microdosing.
Are you interested in talking to people that have been practicing this method for, say, 10 years or more, and finding it quite successful?
Am I interested in talking to people that have been doing it for 10 years or more? I'm not in a position to do that, because my position is I have to be the gatekeeper under this new TGA scheme. We're not in a position to either generate new research or take on, well, we could take on new research. If somebody approached us with a study, we would evaluate that exclusive of this, just as a research study.
Awesome. So I could get some details from you before.
LSD and MDMA and other things like that?
The question is, are they using anything other than psilocybin? Psilocybin is the drug that's been approved by the TGA, just psilocybin for depression, and just MDMA for PTSD. No, they're not using LSD, and I can't tell you why that is, but the literature is rich with psilocybin studies. The Swiss have been using psilocybin, even though, of course, Hoffman at Sandoz developed LSD in the first place. Any other questions? If not, I thank you for coming.
Thank you. Thank you very much, Hudson. That was most informative and enlightening. Now, next up, we have